Hello, everyone, and welcome to our module on atrial fibrillation and Flutter. Let's start by talking about atrial fibrillation, which is a very, very common cardiac arrhythmia. It's one that you will almost certainly see in third and fourth year clinical rotations. And it results in a pulse that is irregularly irregular. That's how the heart is beating. That's how the ventricles are contracting in an irregularly irregular manner. This can cause symptoms like palpitations, fatigue, and dyspnea. We'll talk about this in a minute. And the diagnosis is made by EKG. So if you look over here at these two EKG tracings at the bottom of the screen, the one on the bottom is normal sinus rhythm. And you can see that there's a P wave here, and another P wave here, and another one here. And each P wave is followed by a QRS complex. So this is the normal situation in normal sinus rhythm. At the top, we have atrial fibrillation, and you can see that the baseline is kind of undulating and bumping up and down like this. There may be some bumps that you think are a P wave, but they're not clearly repeated before every QRS complex. So what's happening here is the atria is fibrillating, meaning it's shaking, and that's causing this wavy baseline. And it's generating QRS complexes in an irregularly irregular manner. You can see that these two are close together, and then these two are further apart, and then some are even closer together. There's no pattern to this. It's completely irregular. So here's an entire 12-lead EKG from a patient with atrial fibrillation. Once again, there are some little bumps in the baseline, like what I'm underlining here, but none of these bumps are clear up and down P waves that occur before every QRS complex. They're just random waves in the baseline. We then have QRS complexes occurring in an irregularly irregular manner. So notice that these two are pretty far apart. These two over here are closer together. These two here are also far apart. So the QRS complexes are coming some close together, some far apart. They're varying in an irregularly irregular manner. And here's yet another example just to make this very clear. Once again, if you look at the baseline up here in lead 1, you can see that there are no clear P waves. And then if you look at the QRS complexes, you can see that some are close together, like these two here, but then some are further apart, like this here. And there's basically no clear pattern to the QRS complexes. They're occurring in an irregularly irregular manner. What happens in atrial fibrillation is the myocytes in the atria start depolarizing spontaneously in a completely random manner. So you might have one depolarization here, another one here, then another one here, then another one here. Basically, there are millions of tiny depolarizations of myocytes occurring randomly all throughout the atria. This causes the atrial myocytes to not contract synchronously, so they don't squeeze the blood into the ventricles. Instead, they're just quivering, and that's what the fibrillation of atrial fibrillation is. Some of these depolarizations will send a signal down the AV node to the ventricles and create a QRS complex, but that's going to happen in a random manner. That's what creates that irregularly irregular pattern on the EKG. Sometimes you'll have two complexes reach the AV node quickly and go down to the ventricles. Other times there'll be a pause between two different electrical signals. So what you get on the EKG is random generation of QRS complexes in an irregularly irregular manner. Let's talk about some terminology around atrial fibrillation. So a paroxysm is something that comes and goes suddenly, and that's how atrial fibrillation often behaves. Patients will feel well 1 minute, and then a second later, they will feel symptoms of atrial fibrillation, and then after a period of time, they will go away. So based on this, we have 3 ways we describe the pattern of atrial fibrillation in a particular patient. If we say the atrial fibrillation is paroxysmal, we mean that it comes and goes with spontaneous conversion out of atrial fibrillation and back to sinus rhythm. When we say atrial fibrillation is persistent, we mean that it lasts days or weeks and often requires a procedure called a cardioversion to restore sinus rhythm, and I'll talk about a cardioversion later. And then finally, some patients go on to have permanent atrial fibrillation where it doesn't ever go away. The symptoms of atrial fibrillation vary widely among patients. This is probably something that won't come up on your step 1 exam, but it's definitely something you need to know for clinical rotations. So some patients are in AFib and they are entirely asymptomatic. Other patients have severe symptoms like palpitations, dyspnea, and fatigue. In general, the patients who are asymptomatic often have slower AFib with a heart rate less than 100. The slower the heart rate in AFib, the less likely the symptoms are to be severe. On the other hand, patients with these more severe symptoms usually have heart rates that are very fast, over 100, sometimes even over 150. When the rate of atrial fibrillation is fast, greater than 120 or so, if you leave that untreated for a long period of time, the patient will eventually develop a cardiomyopathy. This is what happens when you have untreated rapid atrial fibrillation, and rapid is the key word. Patients can have slow atrial fibrillation for years and years, and they will never develop a cardiomyopathy. But if it's rapid with those heart rates over 120, 130, that will lead to cardiomyopathy. And we call this a tachycardia-induced cardiomyopathy. There's a loss of left ventricular contractility. The cavity may dilate, the left ventricular ejection fraction will fall, and basically patients develop systolic heart failure if they have atrial fibrillation that is rapid and untreated for a long period of time. Okay, let's talk a little bit more about this phenomena I mentioned, where some patients with AFib have a slower average heart rate. The pulse is always irregular in AFib, but some patients on average have a slow pulse, less than 100. Other patients on average have a very fast pulse. It can be greater than 150 or even 180. And what determines how fast the QRS complexes are going to be generated and how fast the pulse is going to be in AFib is the AV node refractory period. And it's very high yield to know this for your boards. So when an electrical impulse from the atria reaches the AV node, there is a period of time after that called the refractory period where the AV node cannot generate another impulse. If that refractory period is short and quick, then the AV node is capable of sending lots of impulses to the ventricles, and this can lead to a rapid heart rate in AFib. On the other hand, if the AV node refractory period is very long and slow, then relatively few impulses can reach the ventricles, and the average heart rate in AFib will be slow. So in general, young, healthy patients who tend to have very healthy AV nodes with short refractory periods, they often develop a rapid heart rate when they have atrial fibrillation. On the other hand, older patients often have some fibrosis and sclerosis of their AV node. It tends to conduct more slowly, and so they tend to have slower heart rates. One thing to be aware of in AFib is that the rate of impulses in the atria is around 300 to 500 beats per minute. It's very, very fast. But the ventricular rate goes from about 70 to 180. It's rarely higher than 180, and that's because your AV node doesn't allow more impulses than 180 per minute to get through to the ventricles. And it's that AV node refractory period that determines how fast the heart rate is in AFib. Let's talk about another high-yield fact for step 1 around atrial fibrillation, and that has to do with cardiac physiology and preload. So when patients develop atrial fibrillation, their atrial myocytes stop contracting synchronously and no longer squeeze blood into the ventricles, so they lose their ventricular pre-filling by the atria. We say they lose their atrial kick when atrial fibrillation occurs. This is going to decrease the preload to the left ventricle, and it's very high yield to know this. Patients who go into AFib decrease their preload, and this will lower the cardiac output. In some cases, this can lead to severely low cardiac output and hypotension, although it usually doesn't. This is more common in patients who are what we call preload dependent. So for example, patients who have aortic stenosis need a lot of ventricular filling so they can pump all that blood past the stiff aortic valve. If these patients lose their preload, that can lead to hypotension. The same thing can happen when patients have left ventricular hypertrophy or diastolic heart failure. These patients have stiff ventricles which have trouble relaxing to fill with blood, so they can't fill from relaxation, and then if they lose the atrial kick, this can lead to hypotension. But for most patients, there's just a small decrease in cardiac output. It may lead to a slightly lower blood pressure, but it doesn't cause severe problems like hypotension. The greatest danger to patients from atrial fibrillation is that when the atria aren't contracting normally, there's sluggish blood flow along the walls of the atria because they're not squeezing and pushing that blood away from them. And this can be a setup for stasis of blood along the walls of the left atrium, and that can lead to thrombus. And where blood clots and thrombi usually form in patients who have atrial fibrillation is in the left atrial appendage. It's an offshoot of the left atrium where blood flow is always very slow, and it gets even slower in patients who have atrial fibrillation. This image on the screen is a transesophageal echocardiogram image of a patient who has a thrombus in the left atrial appendage. So this is the left atrial appendage here, and this circular thing is a thrombus. This is also thrombus down here. And so this is the feared outcome of atrial fibrillation, that a thrombus will form, and if a piece breaks off, it can cause a stroke. So atrial fibrillation is a classic cause of cardiac embolism. Pieces of clots can break off and go to the brain, causing strokes. They can also sometimes go to the gut, causing mesenteric ischemia. They also sometimes go to the spleen and cause splenic infarcts, which are picked up on CT scans. There's a special subtype of atrial fibrillation called valvular atrial fibrillation. This is traditionally used to refer to AFib associated with rheumatic heart disease, especially mitral stenosis. So when there's mitral stenosis, the blood flow in the atria is sluggish to begin with. If that patient also goes into AFib, then they have very, very slow blood flow in the atria, And so those patients with valvular AFib from mitral stenosis are at very high risk of forming a thrombus and having a stroke. This type of AFib is often refractory to treatment because the atria get big and dilated when patients have mitral stenosis, and there's a very high risk of thrombus. So most AFib is non-valvular, which means it's not associated with rheumatic heart disease, but you'll sometimes hear this term valvular atrial fibrillation, and what's shown on this slide is what it's referring to. Okay, let's talk about some of the risk factors for atrial fibrillation. One of the biggest ones is age. So in patients over 80 years of age, about 10% have AFib. In patients under 55, less than 1% have AFib. So in general, I consider atrial fibrillation to be a disease of the elderly. The older we get, the more likely we are to develop this problem. It's more common in women, and it's associated with other cardiovascular disorders, especially hypertension and coronary artery disease. Patients who have these problems are more likely to develop AFib. And then from a physiologic perspective, you should be aware that anything that stretches and dilates the atria makes it more likely that atrial fibrillation will occur. So patients who have heart failure have high pressures in their left atrium, and the left atrium can get stretched and become big and dilated. Those people are more likely to develop atrial fibrillation. The same thing with patients who have certain types of valvular disease. If a patient has severe mitral regurgitation, there's lots of blood coming backwards from the left ventricle into the left atrium, stretching those left atrial walls, and that can lead to atrial fibrillation. So because of things like this, a key diagnostic test in anyone with new AFib is an echocardiogram, because you want to know if they have some underlying problem like heart failure or valve disease that made them more likely to develop AFib. You should also be aware that patients with hyperthyroidism commonly develop atrial fibrillation. And in this situation, if you treat the thyroid disease and bring the thyroid hormone levels back down to the normal range, the atrial fibrillation also goes away. And it's very important to know if a patient has hyperthyroidism when you're treating them for AFib, because the therapies are generally less effective when thyroid hormone levels are high. So we'll talk later about drugs for AFib and cardioversion, but all those things are less likely to work if you haven't treated the thyroid disease first. So for this reason, besides the echocardiogram we talked about on the last slide, the other important test that all patients with new AFib usually get is a TSH measurement, and that's because you want to make sure they don't have a hyperthyroid condition before you start treating them. Some patients have an obvious trigger for going into atrial fibrillation. Now, most of the patients I've treated over my career have no trigger identified. They spontaneously go into and out of AFib without any obvious thing they did that caused it to happen. But there are some patients where you're able to determine a clear relationship between a certain activity and AFib. One of these is binge drinking. This is called holiday heart. There are some patients who are sensitive to alcohol, and if they drink, they will go into AFib. You should also know that anytime catecholamine levels get very high, this can trigger AFib. This usually happens in the hospital, but patients who are hospitalized with severe infections like sepsis, or patients who've just had surgery, or patients who are in severe pain, all of these things raise the catecholamine levels, and that can trigger AFib. And that's why you'll see a lot of AFib among hospitalized patients. It's all related to these high catecholamine levels. Okay, now let's talk about the treatment for atrial fibrillation. And I recommend you think about all the many drugs that we use to treat AFib as falling into one of three categories. The first category are the drugs used to treat the heart rate. We say these are drugs used for rate control because the goal of using these medications is to bring down the heart rate. Remember what I told you before, fast heart rates are more likely to cause symptoms than slow heart rates, and also fast heart rates can lead to tachycardia-induced cardiomyopathy. So many of the drugs we use to treat AFib simply bring the heart rate down. Ideally, we like to bring it under 110 beats per minute, and that usually minimizes symptoms and eliminates the risk of cardiomyopathy. The second category of drugs are drugs we use to treat the heart rhythm. We say that these drugs are used for rhythm control, and the goal in these situations is to restore sinus rhythm and keep the heart out of atrial fibrillation. And then finally, there are drugs we use for anticoagulation to reduce the risk of stroke. So rate control means using drugs to convert from AFib like this on the left, which is very fast atrial fibrillation, to this on the right, which is much slower atrial fibrillation. And the drugs we use to do this are all shown here. They include beta blockers, calcium channel blockers, and digoxin. So the reason all of these drugs slow the heart rate is because they slow conduction through the AV node. And remember what I told you before, that AV node refractory period is what determines the heart rate. So if you slow conduction through the AV node, you will slow the ventricular rate of the heart. So as I said in the last slide, we often use beta blockers for this, usually beta-1 selective agents like metoprolol or atenolol. They slow conduction in the AV node and they will decrease the heart rate. You can also use calcium channel blockers like verapamil and diltiazem. They also slow conduction in the AV node. And then finally, digoxin can sometimes be used for this purpose, although this isn't done much anymore. Digoxin used to be a popular treatment before beta blockers and calcium channel blockers were available. But the way digoxin works is it increases parasympathetic tone to the heart, so with more parasympathetic activity to the AV node, conduction will slow. So that's rate control. When we're talking about rhythm control for the treatment of atrial fibrillation, we're talking about using drugs or other procedures to restore sinus rhythm. So we want to convert the ECG from something like what we see on the left, which is AFib, to normal sinus rhythm on the right. And procedures that do this, that convert from AFib to sinus rhythm, are called cardioversion procedures. So one way to do cardioversion for atrial fibrillation is to deliver an electrical shock to the chest. This requires a defibrillator machine like what's shown here, and it will deliver a synchronized shock at the time of the QRS. The idea is that right when the QRS complex occurs, this is a safe time to deliver a shock that can convert the heart from AFib into sinus rhythm. If the shock comes later on top of the T wave, that can actually induce ventricular tachycardia and fibrillation, so we don't want to do that. So you synchronize the shock so it will be delivered at the time of the QRS complex. In order to do this, you have to give anesthesia to the patient, then you deliver a shock to the chest. And the reason this works is because the shock depolarizes all the myocytes, and usually the sinus node is the first structure to repolarize and start depolarizing again, and therefore the sinus node takes over pacing the heart and there's no more AFib. You can also use medications to perform cardioversion. This is called a chemical cardioversion. You administer an antiarrhythmic medication. The drug that's traditionally used for this is ibutylide. It's a class 3 antiarrhythmic agent that can be given intravenously. And we don't do this very commonly anymore because of toxicity of ibutylide. Believe it or not, it's safer to use anesthesia and do an electrical cardioversion because once the procedure is over, the patient is able to leave. With ibutylide, there are lingering effects that can lead to adverse events later, so you have to monitor the patient for several hours. And then finally, many patients spontaneously convert, meaning they go back to sinus rhythm without an electrical cardioversion or a drug. This often happens after hours or days. And this is why when patients develop new onset AFib, if they're not highly symptomatic, we often just wait, because if you see the patient a week or so later, they will often spontaneously convert, and this spares them the need of having an electrical cardioversion or a chemical cardioversion. If you decide to perform a chemical or electrical cardioversion, there is a risk of stroke at the time of cardioversion. That's because when the patient's in AFib, the walls of the atria are quivering, but once you do the cardioversion, the walls immediately begin contracting normally, and that can sometimes dislodge a small piece of clot, which can travel to the brain and cause a stroke. So for this reason, if you're going to do a chemical or electrical cardioversion, you have to take some precautions. Now, studies have shown that it takes 48 hours for thrombus to form inside the heart in a patient in AFib. So if the patient has clear-cut symptoms of AFib that began less than 48 hours earlier, then cardioversion is safe. On the other hand, if the patient's symptoms of AFib began more than 48 hours ago, or the patient's unsure when they started, then you have to do one of two things to minimize the risk of stroke at the time of cardioversion. One option is to anticoagulate the patient with drugs, which we'll talk about in a minute, for 3 weeks, and then you can safely perform the cardioversion. The second option is to perform a transesophageal echocardiogram. This can get those up-close ultrasound images of the left atrial appendage like we saw earlier in this video, and you can exclude the presence of thrombus, and then immediately after the echocardiogram, you can safely perform the cardioversion. Now, one exception to all these things I've written here is hypotension or shock. If a patient has hypotension or shock from rapid AFib, then you perform an emergent cardioversion and you accept the risk of thrombus because the shock is a life-threatening situation. So I told you before that the goal of rhythm control is to restore sinus rhythm through some type of cardioversion, but you should be aware that rhythm control also usually involves some type of oral daily antiarrhythmic drug. These are started before or after cardioversion, and the idea is that the drug, which the patient takes every day, will suppress AFib and make it more likely that they stay in sinus rhythm and don't revert to atrial fibrillation. We sometimes use class 1 antiarrhythmic drugs for this. I talk about these in another video. These are drugs like flecainide and propafenone. We also often use class 3 drugs. The ones that are commonly used are amiodarone, sotalol, and dofetilide. The third arm of treatment for AFib is anticoagulation. This is necessary to reduce the risk of a clot forming in the heart and the patient having a stroke. There are a number of options for anticoagulation. Warfarin is the old standard, although it's not used much anymore. The downside of warfarin is that you have to monitor the INR with regular blood tests, and the goal is an INR of 2 to 3. And I talk about warfarin in more detail in videos in the hematology section on anticoagulants. In the modern era, we are more often using drugs like rivaroxaban or apixaban. These are factor 10 inhibitors. They're oral drugs, and you don't have to use blood tests to monitor the INR. There's also a drug called dabigatran, which is a direct thrombin inhibitor. It's also an oral drug that doesn't require INR monitoring. And then finally, aspirin can theoretically be used for anticoagulation. It's not really an anticoagulant. It's an antiplatelet drug. It's less effective, and it's usually only used if the risk of stroke is very, very low. The upside is it has a low risk of bleeding, but most of the studies have shown that aspirin is not very effective in preventing blood clots and strokes in AFib. These drugs are all generally used instead. A very important thing to know about anticoagulation, not just for your boards, but also for clinical practice, is that you have to administer anticoagulation whether the AFib persists or sinus rhythm is restored. The studies have been very clear on this, that there's a similar stroke risk in patients with AFib, whether they stay in AFib or whether they revert to sinus rhythm. The reasons for this are unclear, but probably it's related to the fact that the atria in patients who have AFib are not normal, and therefore they're more prone to developing blood clots along the surface of the myocytes. It's also likely that patients who we think are in sinus rhythm have intermittent, very short bouts of AFib from time to time, and that could cause clot. But whatever the underlying explanation, the bottom line is that anticoagulation is imperative, and it doesn't matter whether the patient converts back to sinus rhythm or stays in AFib. Because there's a risk of life-threatening bleeding when patients take anticoagulants, we don't give anticoagulant drugs to every patient who has AFib. We only give it to the patients at the highest risk of stroke. And to determine the patient's risk of stroke, the most commonly used tool is the CHA2DS2-VASc score, which is shown on the slide here. It's a point system, and you total up the points for an individual patient, and that helps you figure out whether or not they should be on anticoagulation. So the points for the CHA2DS2-VASc score are all shown on this slide. Heart failure, hypertension, and diabetes are all 1 point. History of stroke is 2 points. Female gender is 1 point. Age 65 to 75 is a point. Age over 75 is 2 points. And finally, vascular disease is 1 point. So the way you use the CHA2DS2-VASc score is you total up the patient's points, and if they have equal to or greater than 2 points, then they should be on anticoagulation. If they have a score of 0 or 1, then they don't need to be on anticoagulation. The one exception is that if patients have female gender, which is 1 point, and they get 1 point from something else, maybe hypertension or diabetes, that would be 2 points, but it's no anticoagulation in this case. And that's because females who have only one other non-gender related point turn out to be at relatively low risk in contrast to men. And so therefore, when you get to 2 points by female gender being one of the points, you don't have to give anticoagulation. So that's a lot that we've been through in this video, but here's a summary slide of how to handle new onset atrial fibrillation. So remember what I said before, in an unstable patient, emergent cardioversion is the way to go. Most patients should have an echocardiogram and a TSH measured. That's because you want to know if they have heart disease, and you also want to know whether or not they have hyperthyroidism. Then you can do rate control with these drugs here, or you can do rhythm control by performing some type of cardioversion and then administering antiarrhythmic drugs. And then finally, all patients need anticoagulation, and this is based on the CHA2DS2-VASc score. There is one surgical therapy for the treatment of atrial fibrillation. It's called a pulmonary vein isolation. And I'll explain what this is by zooming in on the left atrium in this cartoon on the screen here. So in the left atrium, you usually have 4 pulmonary veins that drain into the left atrium. And it turns out that the trigger for AFib in many patients is electrical activity that originates out here in the pulmonary veins, travels down into the atria, and then triggers the onset of atrial fibrillation. So if you can electrically isolate the pulmonary veins, then electrical activity cannot be transmitted to the atria. And that's what's done in a pulmonary vein isolation. Special catheters are inserted into the heart, And basically, they burn just a little bit of scar tissue around the rim of the pulmonary vein. And this makes it such that the pulmonary vein cells can no longer conduct electricity towards the atrium. And so you've electrically isolated the pulmonary veins. That's why it's called a pulmonary vein isolation. And in the right patients, this can dramatically cut down on the number of episodes of atrial fibrillation. Okay, I'll finish this video by talking briefly about atrial flutter, which is sort of a cousin of atrial fibrillation. So this EKG on the screen here shows atrial flutter, and the hallmark are these so-called sawtooth patterns in the baseline of the EKG. You can see it here in lead 3. You can see it there in lead 2. It's also easy to see down here along the bottom. You've got a baseline that's going up and down like this, followed by QRS complexes. These are called sawtooth pattern, and that's the hallmark of atrial flutter. So we talked earlier about how in atrial fibrillation, there are those millions of little depolarizations happening all over the atria in the heart. Well, atrial flutter is different. What's going on electrically in atrial flutter is there's a reentrant circuit, meaning a circuit of electrical activity going around the tricuspid annulus, and that's what's generating those sawtooth waves. So if you look at my cartoon on the slide here, the annulus is the tissue that surrounds the tricuspid valve, and it's sort of circular in shape or oval in shape. And what happens in atrial flutter is, for reasons that are incompletely understood, patients develop an electrical circuit going around that tricuspid annulus. And every time a circuit goes around, it generates a little sawtooth wave. And then some of those sawtooth waves are transmitted to the AV node and go down and generate a QRS complex. And so that's what creates the EKG pattern of sawtooth waves followed by intermittent QRS complexes. The symptoms of atrial flutter are generally the same as atrial fibrillation. This arrhythmia can be asymptomatic, but it can also cause palpitations, dyspnea, and fatigue. And the treatments are also similar to atrial fibrillation. You can do rate control or rhythm control. You can use rate-slowing drugs like beta blockers. You can perform electrical or chemical cardioversion. And just like in atrial fibrillation, there's a risk of clots forming in the left atrial appendage. So you have to give the patient anticoagulation based on their stroke risk using the CHA2DS2-VASc score. So earlier I told you that there's a surgical treatment for atrial fibrillation called pulmonary vein isolation that, as the name implies, involves the pulmonary veins. Well, there's also a surgical treatment for atrial flutter. It's called an atrial flutter ablation, but it does not involve the pulmonary veins. Don't confuse the two surgical procedures. For atrial flutter, the ablation procedure involves ablating tissue on the isthmus between the IVC and the tricuspid annulus. So let me explain what I mean by this. So the IVC enters the right atrium around here, and close to where it enters, there's some tissue of the isthmus, which is that ring around the tricuspid valve. And so what happens in an atrial flutter ablation is a small amount of burning is done right here to create scar tissue. Once that happens, you can no longer have that macro reentrant circuit because there's disruption to electrical conductivity by the scar tissue here. So that's the treatment, an atrial flutter ablation. This is much easier to perform than a pulmonary vein isolation for AFib. It's much more likely to be successful. So it's often used in patients who have recurrent atrial flutter because it can be curative. And that concludes our module on atrial fibrillation and flutter.